and blood pressure and that sort of thing, as you already know.
And so this doesn't mess your exam up. What was y'all's content today, GI?
Yes.
So the exam will still be on the same content, we can switch it up a little bit. Does anybody have any questions? Y'all, we're getting close. I mean, this semester's flying by, is it to y'all? Yeah. So I want to ask a yes or no question, but I shouldn't. No, I'm trying to think of a different way to phrase it. So is a yes or no question good?
No.
So I want to know if you feel like you've grown and learned a lot this semester. But y'all were saying yes. What would be a better way for me to phrase that? Tell me how you've grown, or tell me how you feel, or whatever. How do you? I mean, you're learning. You've started learning a whole new language, all kinds of stuff. November the 1st is drop day. So this is the last exam before drop day, right? So, okay. Questions about that? All right, no questions. We're going to get started on renal. What is renal? What are we going to talk about today? Okay. So this very first slide that's going to come up to me is so good, because we're going to talk about what all the kidneys do. And it's really fun to think about when we start talking about kidney disease and kidney failure. All the signs and symptoms that a person has and the things they experience are all related to the kidneys not being able to do what they're supposed to do. So before we even look at the next slide, you may have already taken a peek. Who knows some things that the kidneys are responsible for? What do you think about? What is the first thing you think about? Clearing out waste products. They're like a water treatment plant. 7 liters of fluid an hour are filtered through your kidneys. 7 liters of fluid an hour. Now, do you pee 7 liters an hour? Sometimes you would die if you did. So 99% of that is returned back to the circulation, and the 1% of that will become urine. So they're a water treatment plant. They're cleaning out waste products from your body. What else do you know? What else do I hope you remember, because I taught about it? Yes. Say it loud. They do regulate blood pressure. They how do they? So y'all love that renin. Y'all know it now. That renin-angiotensin-aldosterone system. How do the kidneys contribute to that? What makes them release renin? Drop in blood pressure, drop in volume, and that whole system starts. And why does your blood pressure increase? Vasoconstriction, number 1, from that angiotensin 1 becoming 2. And then what did you say, Paul?
Holding sodium and holding water, increasing
The volume, yeah. So sodium in water is, who does that? Aldosterone, and that's all part of that system. Good. Another way kidneys regulate volume is volume. Like if we go and drink a whole lot of water, what happens to you? You go pee every 5 minutes, right? And what if you didn't? What if you kept drinking these giant Stanley cups and drinking them and drinking them and drinking them and drinking them, and you never went to the bathroom? Would your blood pressure go up?
Yeah.
It would. So that's another way your kidneys regulate your blood pressure. You still hadn't hit on something I want you to say. That was good stuff. Acid base. Y'all remember? Acid base, what do the kidneys do? They get rid of metabolic acids. What are some examples of those? Lactic acid, acidic, anything that's not what kind of acid? Carbonic. So the kidneys get rid of metabolic acids, and what do they secrete or excrete to get rid of an acid? Hydrogen. And what can they hold on to that's a base or make more of? Bicarbonate. And then sometimes the kidneys have to help the other system. They have to help the lungs, right? Good. Good remembering. Let's see, what didn't we remember? Glucose. Do y'all know your kidneys have something to do with your glucose homeostasis? We're going to talk about that in just a little bit, but your kidneys, when they're filtering all that 7 liters of blood per hour, glucose is filtered in. You know, glucose goes through that nephron as well, and there's a certain point on that nephron where the glucose is sent back into the bloodstream. So it helps us with that, and I'll go more into that when we get to that part of the kidney. So glucose regulation is very important, part of what the kidney does. What about this vitamin D stuff I've got here? Activation of vitamin D. So vitamin D has to be activated for us to absorb calcium. So what system do you think would be effective if we could not absorb and use calcium? Our skeletal system, yeah. So if we didn't have calcium, our body needs it and it's going to get it. And where does most of it live? In our bones. And so our body's going to pull it out of our bones. So if we didn't have activated vitamin D to help us absorb that calcium, we'd have thinning bones or osteoporosis. And we need calcium for cardiovascular function as well. Did y'all know the kidneys did all this stuff? Do y'all know about this thing right here? Erythropoietin. Your kidneys make that. You know what that does? It tells your bone marrow to make blood cells, red blood cells, white blood cells. So do you think somebody who has kidney disease might have anemia? Yeah. Yeah. So all of these things the kidneys do. So really, if the kidneys are not functioning like they should, every system of your body will be affected. You know, you'll have, in fact, when somebody has kidney disease, one of the main causes of death from that is cardiovascular complications. So kidneys have a lot to do with, let's see, did we miss anything? Nope. Anatomy, let's remember it. This is our urinary system, so you have 2 kidneys. Maybe. Most people do. Some people have one giant horseshoe-shaped kidney. Some people have more than 2 kidneys. That's called supernumerary kidney. And that's okay, as long as they're functioning like they should. I have a friend who found out later in life she had 3 kidneys. So, yay, for her. Okay, and that's okay. Okay, and then you've got, so they're in the retroperitoneal cavity, and they're kind of prone to injury from movement, like horseback riding or like motorcycle riding, like through the woods or whatever, what's that called, dirt bike and all that. Anything that can jostle your kidneys, they can be prone to injury because they're just located in that retroperitoneal space. The right kidney is lower than the left a little bit because it's kind of tucked under the liver. And then you have the ureters. What's their job? Yeah, they drain urine by gravity. They're about 18 inches long. They drain by gravity, but they also drain by peristalsis. Do y'all remember what that is? That rhythmic contraction, kind of like you have in your intestines to move waste products along. Your ureters have peristaltic action as well. And then you have the bladder, which holds urine until you gotta go. And we'll talk about that a little bit later too. And then the urethra. This is the prostate gland in a male, and so I want you to see that and notice where it is, and it's kind of like around this urethra. So what do you think would happen if this was enlarged? You think the male would have a hard time going to the bathroom? Yeah, that's called benign prostatic hypertrophy, BPH. And so just letting you know anatomically where that is. We'll talk about that a couple of times today. All right, so to really and truly to understand kidney function, you have to understand what the kidney does at the cellular level, at that nephron, which is the functional unit of the kidney. And so we're going to break it down. And you may not love this part, but I hope you do. I do, because it's really interesting and it helps you see what's going on in some of the conditions that we talk about today. But this is an overall view of the kidney. So this is the pelvis right here. And this is where urine collects. And then it drains on down the ureter. These are the pyramids. And parts of the nephron dip down into that. Parts of your, the tubules that we'll talk about. And then this cortex is where the glomeruli, most of them, and most of the tubules live. So that's that. That big old 7-liter blood supply that enters this renal artery, filter, and 99% of it comes back out, with 1% being urine. Okay, so this is the nephron. This is the functional unit of the kidney. We have about 1 million nephrons per kidney. Because of that, we say that we have a very large renal reserve. Y'all know what that means? Renal reserve. If we have 1 million nephrons per kidney, we're not using all 1 million of those all the time. And they all can do the same thing. That's why, do you think you can donate one of your kidneys and still maintain kidney function? You can. So we have lots of nephrons giving us a large renal reserve, which is good. So here are the jobs of this nephron. Filtration of water. We talked about it's a water treatment plant, waste treatment plant rather. We resorb. The word resorb means, y'all remember that? Bring things back into the bloodstream. So we resorb glucose, electrolytes, and things like that. And then we get rid of waste products. So this is the nephron with all the arteries and veins surrounding it. Now let's break it down to the parts. And this is where it really gets interesting, really, and important. Because this glomerulus right here, this is it. This twisted network of capillaries right here. This is where the party begins. Right here. This is where the filtering begins. Important concepts, very important concepts to get right now. What do we need for this party to get started, for this process to get started? We've got to have hydrostatic pressure, blood flow, volume. We've got to have push. Y'all remember that hydrostatic pressure that Dr. Wright talked about? It's push. That's what gets this whole thing started. You've got to have push, hydrostatic blood pressure to get this filtering going. So knowing that, thinking back to what we just had a test on, decreased cardiac output. Remember one of the signs of forward failure is decreased cardiac output. One of them was oliguria, which is a low urine output. This one. Because if you have low cardiac output, are you going to have good hydrostatic pressure and push here? That's why they have a low urine output, y'all. Decreased cardiac output. Also, if somebody has a really low blood pressure from hemorrhage or whatever, what's their urine output going to be? It's going to be low because you're not going to have that volume of push. That's such an important concept to get. Y'all, that's why in ICU, we're doing at least Q1 hour urine outputs, sometimes Q30 minute urine outputs, because that tells us a lot about what's going on. Does it tell you what's some stuff going on with the heart, maybe cardiac output? Tells you about volume. Could it tell you about septic shock? What if you're massively vasodilated from septic shock? What's your pee gonna be like? Nothing. because you're not gonna have any push, because you're gonna be so vasodilated. Does that kind of all make sense? That's, urine output tells us a whole lot about our critically ill patients, okay? And about you. All right, so it's very permeable. It lets a lot of stuff through. If I were taking notes, and I hope 178 of you are, this is very important. It's in red. It lets a lot of stuff through, but it doesn't let blood cells and protein through, which are large particles. How many of you pee bloody urine? Don't raise your hand. Would that be normal if you did? No. Thank you, glomerulus. Thank you, glomerulus. You're not letting red blood cells through. So what do you think if you see blood in somebody's urine? Could there be something wrong with this filtering part of your kidney? Yes. Okay? So it's not, is it ever normal to have blood in your urine? No. No. Well, maybe if you had surgery on your bladder, but normally it's not a normal finding. Proteins. What would happen, and we're going to talk about it, if you were peeing out lots of your body's protein? Do y'all remember that we need, so we've already talked about hydrostatic pressure. What's the other pressure that proteins help with? Oncotic pressure. What do they do? If hydrostatic pressure pushes, what do proteins do? Pull fluid back into the vascular space, right? What if I'm peeing out all my protein? What am I going to look like? Edema, edema, edema. Because what do those proteins do? They pull fluid back in. So we don't want to lose all our, and proteins do other jobs too, okay? So I know I'm harping on this, but when we start talking about glomerulopathies, do you think these people are going to have protein and red blood cells in their urine? Yeah, if something's wrong with this part of the body. I hope y'all think that's so wonderful. Okay, this is just a picture of it. Yay, I love pictures. When you're studying, I believe in looking at pictures because it helps you. Okay, this is another number you need to know. Of course, we have to have a normal value for the rate at which your glomeruli filter. And so this is a number that you should learn. The GFR, or glomerular filtration rate, for normal is 90 to 120 milliliters a minute. That's normal. Now, as we age, I will tell you this, you've probably got your peak GFR about 30s and 40s. And it tends to decrease by about 10% per decade. 10% per decade of life. So what we already know, let's remember why this is important for old people. We already know that old people have a hard time with fluid balance and all that, don't we? Could this be one reason? They tend to get fluid overloaded very easily. Well, if they're 80, their GFR is probably half of this, of a 30-year-old. So what do you think? They're going to get volume overloaded more easy. Does that make sense to y'all? So very old, very young. So enjoy your GFR, because you've got a good one right now, but it does decline 10% per decade. So that, what do your kidneys do too? Do they get rid of drugs, metabolized drugs and things like that? So when we talk about old people, do they need sometimes lower doses? Yeah, good thinking. All right, so what this means is, so each nephron has a glomerulus. Sometimes we got 1 million per kidney, right? They can all do the same thing. Every one of them. They can all filter, they can do all this stuff. And it's regulated as long as you've got a decentish blood pressure. If your blood pressure systolic starts to get super high or really low, your GFR is going to be affected. Y'all hear so much talking over here. Woo, 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 just woo, 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 woo. It's disturbing to me. Kind of like that thing outside that keeps pounding all day long. All right. Okay, we talked about blood volume. So how do we know your GFR is good? One test we can do is a creatinine clearance. It's a 24-hour urine. And Miss Cooper's going to teach this afternoon. And yay, everybody loves Miss Cooper. We can do a 24-hour urine, which means we collect all of the urine somebody expels for 24 hours. And then we can send it down to the lab and look at it, and this gives us a good idea of a person's GFR, glomerular filtration rate. Because creatinine is a waste product that's neither absorbed or nothing. The kidneys have nothing to do with it; they just get rid of it, and so we can kind of tell. Okay, that was this part. That's the glomerulus. What does it need to get the party started? Volume and hydrostatic pressure, yes. And then it pushes here. This is Bowman's capsule. It's really not TT yet. It's called filtrate. It's beginning urine. It's beginning to turn. It's beginning to look a lot like Christmas, but not yet. Okay, so the next part is the proximal tubule. This is the next part. Remember all that blood that goes in 7 liters an hour? Well, a lot of that is restored back into the bloodstream right here. You know, that potassium and stuff we need, it goes back into the bloodstream. And here's that glucose that goes back in. So, did we say that it was, is it normal, do you think, to have sugar or glucose, it's called glycosuria, in your urine? Is it normal to have sugar in your urine? Glucose in your urine? No. Okay, it's not. So what your kidneys can restore glucose up to about 180. When your blood sugar gets to like 180, which is high, you start spilling some glucose into your urine. When your blood sugar gets around 300, which is very high, you start spilling lots of glucose into your urine. And what that's called, when you have sugar in your urine, that's called exceeding the renal threshold for glucose resorption. So I wonder what type of people may, or what condition may cause somebody to spill glucose in their urine. Diabetes, high blood sugar, we check that urine dipstick, it's got presence of sugar in it. That's not normal. We don't want that to happen. That means your blood sugar's high. Okay, party started. What doesn't this let through? Red blood cells and protein. Okay, we got down the proximal tubule. Now we're in the loop of Henle. Loop of Henle. Y'all are not in pharmacology, but we give diuretics called loop diuretics. A type of diuretic is a loop diuretic. Where do you think it acts? Furosemide or Lasix is a loop diuretic. Anyway, what happens here is, this is filtrate, this is still filtrate, but it's getting more concentrated. 7 liters went in here, now 60% of the water went out here. Can you see in your mind the urine getting more concentrated? Okay, so that's what happens here. It becomes more concentrated, this dips down into some of those pyramids. Sodium, chloride, and potassium are kind of put out into the interstitial space, making it very high concentration, and that just continues to pull fluid, concentrating that urine. Okay. Yeah, oh look. Hey. Works right here. Aldosterone, secreted by who? The adrenal glands. Yeah, this is where this part of the nephron is what responds to that aldosterone. To say, oh, do I need to conserve water and sodium? Okay? And this is further concentrating urine if we need to. Then it goes down into the collecting tubule, which responds to ADH. Y'all remember ADH? Who secretes that? Pituitary gland. And what does that do if it's secreted? Antidiuretic hormone. Yeah, we're going to restore more water. Okay, good. Okay, out of that 7 liters per hour that went in, Y'all, this is what you need to know from now until the rest of your life as a nurse. And when you retire, you still need to know it. This is normal urine output. The minimum urine output that we will consider normal is 30 milliliters an hour. So when I was working in ICU, if my patient's urine output dropped below 30, what do you think I did? I called somebody. Something's wrong. We started drawing labs, all kinds of stuff. Something's wrong. So that's your normal urine output. Now, who in here knows how much they go per? Do y'all go every hour and no? So how do you kind of know? Yeah, color sometimes, and we'll talk about that. Woo! This is what we've talked. This is what we've already talked about, y'all. Just the arrow part we're worried about. Angiotensin, aldosterone, sympathetic nerves, antidiuretic hormone. You don't have to memorize this chart or learn what part of the nephron these react on, but hormonal regulation happens. Does that look kind of good? Tell me why that looks good. Y'all know. Why does that look good? Because it's what? There's no blood in it. I love that. Could there be blood that I didn't see? Yeah, there could be microscopic blood. There's no gross blood. Why else did we love that?
Pale amber.
It's pale amber. What would it mean if it were, I'm looking for an orange shirt. I don't see one. Anyway, what would it look like if it was really like dark orangey? What would that tell you, maybe?
Dehydrated.
Yeah, you could be dehydrated. You need to drink more, right? Looks like it's probably enough if that was in an hour. This is clear, isn't it? What if it were like cloudy? Like it looked like it had mayonnaise stirred in it.
Infection.
Does that sound gross? What was it? What would we have?
Infection.
Infection. Cloudy urine. We want it to be clear, yellow, maybe slightly amber. Do we want it to smell bad? We know what urine smells like, okay? It's not perfume, but you know, when you have an infection, it has a certain smell. When you eat asparagus, that too. Right. Now, sometimes our urine turns a color because of what we eat, like beets. Or certain medicines. If anybody's ever taken Peridium for a UTI, it turns your urine like a rusty red color. So do you think you need to tell your patients that if you gave them that medicine? Because they're going to go to the ER thinking they're dying, and it's from their medicines. Okay? You need to learn these, y'all, forever and always. This isn't just for this class. This is for your career and for a million tests from here on out till you graduate and in class. You have to know labs that test kidney function. BUN and creatinine. They're usually done together. BUN stands for blood urea nitrogen. This is nitrogenous waste. It's a byproduct of protein metabolism, but it can also be affected by your hydration status. If you're very dehydrated, it can make your BUN elevated. If you're overhydrated, it can change the value of your hydration status. And if you decide that you're going to go on one of those diets where all you eat is meat, you're on a meat diet. All you eat is protein, which is not the best idea in the world because we need everything. But do you think it could affect your BUN? Yes. Okay, so the reason I say that is because BUN can tell us about kidney function, but it is affected by other things. So it's not the best. The best is creatinine. Creatinine. That is a byproduct of muscle metabolism, and that is a very good lab. It's not affected by hydration status. It just runs on through the kidney, and great one, okay? So you need to know these values, okay? This is a byproduct of muscle metabolism, so that's why it's slightly higher in men, because they tend to have a little bit more muscle. Okay? So this reflects our GFR, which stands for what? Very good. Okay? So y'all have to know these labs, okay? Please know these labs. Okay. So this is the CVA, costovertebral angle. This is the external landmark of the kidneys. So it's where your rib cage meets the spine. So if somebody, have y'all done this in assessment yet? No? Okay. So you see what this person's doing? They're putting their hand on the person's back, and they're not doing this with all their might, but they're giving a little. If the person has like pyelonephritis or a kidney infection, if anybody's ever had one, that's painful. So this is an external landmark of the kidneys, and sometimes we'll say the person has CVA tenderness. We think they could be having an infection, and we'll be talking about that in a little bit. I already told y'all that. Old people. Okay, look. Ooh. Young, old, okay? We already talked about they're more susceptible to fluid, all that, decreased 10% per decade. Not as, you don't have 1 million nephrons per kidney anymore, so you have less reserve, okay? Y'all already kind of knew that. What is this? What is contrast media? Yes. Like if somebody's going to a CT scan or an MRI and they're having contrast, they will inject contrast materials, IV, all different kinds. Gadolinium is one of them. I don't know all of them. But we have to be really careful with people who are older, who have kidney disease with contrast media. Oh, okay. What's the underlying mechanism which results in glycosuria? B, we exceeded the threshold for glucose resorption. What does resorption mean? Sending it back into the bloodstream. When does it start to spill? At about 180. When do you get a lot? You start going over 300. Is glucose in the urine ever a normal finding? No. Even in diabetes, it's not a normal finding. We don't want them to be spilling sugar in their urine because that means that their blood sugar's high. The main driving force for glomerular filtration. Yes, it's B, hydrostatic pressure. That's that push, hydrostatic. You've got to have that push, y'all. It's all about that push. All about that B. Okay. All right. So, what would increase glomerular filtration? What would increase glomerular filtration? A, fluid volume excess, yeah. Just like y'all drinking water, I hope. Then that's going to increase your GFR. What's the answer to this one? C. Because creatinine is a byproduct of muscle breakdown. Sometimes older people, really old, frail people, could have a lower creatinine because what's their muscle mass probably like? Lower. What substance will cause a decrease in urine output? B. I would pick that because have we even talked about or heard of the other ones? Right. Okay. So we talked about normal. Now we got to talk about not normal. Okay. Renal disorders. Glomerulopathies. I'll say that fast 3 times. Glomerulopathies. Typically, these are classified by the degree of proteinuria. What does that word mean, do you think? Proteinuria.
Protein in the urine.
Protein in the urine. And how do we know that's a glomerulopathy? Because what's that glomerulus's job? Not to let protein through. So, something that's wrong with your glomerulus, many times we'll classify it by the degree of protein in the urine. Nephritic syndrome we're not going to really talk about too much. We're going to talk about nephrotic syndrome, which is a large amount of protein loss in the urine. Another thing that I would probably take note of is glomerulonephritis, which is an inflammation of the glomerulus, typically follows a streptococcal infection. Okay. So what's the trigger? If I were making a chart, or a concept map, what typically is the trigger for a glomerulopathy is some kind of infection. Like I said, strep. And this usually happens like 7 to 14 days after a strep infection. Why do you think? Because that's how long it takes to build up these antibodies. So, when you go in with something going on with your kidneys, they may say, have you had an infection lately? Or even impetigo, like a skin infection. Systemic disease. Oh, yeah, let's talk about that. Diabetes. Lupus. These systemic autoimmune diseases can affect the kidneys, okay, and cause glomerulopathy. These antigens, these antigen-antibody complexes attack the glomerulus of the kidney, many times in autoimmune disease. Okay? Oh, me, there's a flow chart. All right, so here's that antigen. So if I were doing a concept map, I'd say, y'all, this is an antigen-antibody reaction. This is triggered by some sort of infection, typically bacterial. It can be other types of infection. And those complexes cause damage to that nephron. Okay, so let's look at this. Well, that makes sense, doesn't it? Albumin, which is a protein, and red blood cells are going to be lost in the urine. Okay? Proteinuria is the name for that. You may see it termed microalbuminuria. And that can be seen on the microscope, albumin in the urine, okay? Y'all, look at here, we've already talked about that. Diminished oncotic pressure, because you're losing all your protein, you don't have that pull, you're going to have edema. Make sense? Not going to have much urine. Y'all know what oliguria is? Less than 400 milliliters of urine in 24 hours. That's what oliguria is, so that's not good, is it? And then decreased GFR, so you're going to have too much volume, edema, and your blood pressure goes up. So here it is, the big reds. Do they still make big red gum? Mm-hmm. This is the big reds for glomerulonephritis. Other things can be there, but these are the hallmark classic findings of glomerulonephritis. Edema. What does hematuria mean, do you think? Blood in the urine. Proteinuria or microalbuminuria and hypertension. Now, instead of memorizing those, which I kind of hope you do, because those are the hallmarks, but do you see why those happen? That's what I really want you to see. Why do they happen? And if you know what the job of the glomerulus is, you can figure out why they happen. okay? Smoky or coffee colored urine, it's old red blood cells. You know, it'll be dark. Sometimes it might be bright red, or they may be old, broken down red blood cells, dark. Kind of like the color of these chairs y'all are sitting in. And then, can you see protein in the urine? Actually, not if it's microalbuminuria, but if there's a large amount of protein in the urine, it's kind of foamy looking. This color and foamy, okay? That's not normal. Right? They may have CVA tenderness, but these are the big reds, okay? So how are we going to diagnose it? A patient said, oh, I just had a strep throat 14 days ago. Oh, my little antennas go up. Do yours? Yeah. Okay. Elevated BUN and creatinine. Are those labs for kidneys? Which one is most specific? Creatinine. Very good. They might have a little bit of anemia. Which means what? What is anemia? Decreased red blood cells. So why would that happen?
Because they're peeing it out.
They could be peeing it out, and maybe the kidneys aren't working with that erythropoietin too. So we're going to do a urinalysis. We're going to check that. What does serum albumin mean?
Like from blood.
In their blood. In their blood. So what are we going to do? Supportive care means treat the symptoms. We're going to treat the symptoms, you know. If they're infected, well, they're going to get antibiotics. If they got a fever, we're going to give them antipyretics. If they're in pain, we're going to give them analgesics. And y'all, it can be so bad that they need dialysis. But did y'all know that dialysis can be temporary? A lot of people are on permanent dialysis for the rest of their life. But we can do a temporary dialysis for people that have screaming high hyperkalemia. We can do it, or we can do it to let the kidneys rest until, you know, your antibiotics start working and all that. Y'all are squirming. What time is it? It's almost time for, we've got to get through glomerulonephritis. That wouldn't make sense right now. All right. So that was acute. This can go chronic. This can become a chronic problem. And y'all know what chronic means. It's not over quick. It may last months, years, or ever. Right? So this can go into end-stage renal disease. When we start talking about ESRD, end-stage renal disease, these people are dialysis candidates, a lifetime kind. Okay. So over time, the nephrons are scarred. Here's another cure for that. Transplant. So we'll be talking about that in a little bit. This is still glomerulopathy, so hang tight. Remember we talked about they're categorized many times by the degree of protein loss. When you have a large amount of protein loss from a glomerulopathy, like glomerulonephritis, it's a lot to say. Things can happen when you lose a lot of protein. And I do have a good flow chart I want you to look at. Okay, here we go. This is a very good chart. I would take notes on this. So you've got, whatever reason, your glomerulus is in a mess. Okay? What could have caused it to get in a mess? Yeah, like strep throat, some kind of infection, or maybe they've got diabetes or lupus. Or something is attacking that glomerulus. It's an antigen-antibody reaction for whatever reason, and the glomerulus is not doing good. It's not doing its job. And so you've got protein in your urine. This means you've got hypoalbuminemia. That means decreased albumin in your blood. So let's see what happens. Lord have mercy, the liver gets involved. The liver says, Lord, they're losing all their proteins necessary for hemostasis, which means clotting, right? So the liver says, well, let me help. And it starts making tons of clotting factors. And so guess what this person becomes a candidate for? Blood clots. okay? Because your liver tries to help by making clotting factors, okay? And it also says, for some reason, I need to make some more lipids. So that's how the liver responds to this. Making more lipids, which causes you to have hyperlipidemia. Then we know that ain't really, don't we, from today's test. And clotting factors. So we've got now hyperlipidemia and risk for clotting. So that's what the liver did for us to try to help out. Now let's look and see here. We got low albumin in our blood. We talked about that decreased pressure. Decreased volume. Y'all already know about the renin-angiotensin-aldosterone system. Sodium and water retention, edema. Decreased plasma oncotic pressure, edema. Do you see that big old arrow? What's it pointing to? Edema. These people are edematous. So here's the big reds of that one. Nephrotic syndrome. They've got hyperlipidemia. What does that set the stage for? Cardiovascular disease, that's right. Edema, especially periorbital, and that means around the eyes. Around the eyes and face. Okay? There's other places, but that's kind of a clue right there. Where is ascites edema? In your belly. Okay? And then we've got hypercoagulability, which means clots. This ain't no good, is it? Nephrotic syndrome. Okay? So how do we treat it? Well, diuretics. What do they make you do? Edema. Low sodium diet. Helps with that edema. Lipid lowering meds. Helps with that. Immunosuppressive therapy. Well, if it's lupus or diabetes or even rheumatoid arthritis or any autoimmune disease, immunosuppressants. And then hypertensive therapy, because they do have hypertension from volume overload. Another thing that can happen that is not good with our kidneys is we can have an obstruction. It's a blockage of some sort. It wouldn't be good. So it can occur anywhere within the system. So what's the system? The kidneys, ureters, bladder, urethra. That's the system. It causes stasis of urine. And what does that word stasis mean? Still, it's not moving. Urine that doesn't move becomes a medium for bacterial growth. We got to have that stuff moving. Okay? So that's why it predisposes to UTIs, which we'll talk about a lot today, and acute renal failure. Here's that system. You don't have to memorize this, okay? Like what all can cause an obstruction. This is a stricture, fibrous fan. BPH can cause it, benign prostatic hypertrophy. We're going to talk about polycystic kidney disease. But many things can cause an obstruction. The main one we're going to talk about is nephrolithiasis. Y'all, that's a kidney stone. Y'all heard of those? They are bad news. What's the baddest news about them, do you think? Pain. That's the baddest news about these. So nephrolithiasis. Nephro means kidney. This means a stone. They're also called like a renal calculus. And they're kind of named by where they are. So nephrolithiasis, that could be in the kidney. If you have a ureterolithiasis, where do you think that is? In the ureter, right. So kidney stones, the ones in the kidney, are very common. Look at us. We live in the place where it's the highest risk of getting a stone. Why is that? It's hot. Y'all, it's hot and I would say dry, but we're the rainiest city in the country, but it's hot. Dehydration or low volume is one of the main risk factors for getting a kidney stone or developing a kidney stone. People always say sweet tea, and it probably does have some, could have something to do with it. Y'all drink sweet tea? Who does? You know, when you go on vacation somewhere up north, they never have sweet tea. They'll get you some sugar to put in it. No, thank you. It doesn't work right. I don't know why more white people. I don't know why more males. Hey guys, males, you got a 12% chance in your lifetime of getting a kidney stone. Congratulations. Females have a 7% chance of getting a kidney stone in your lifetime. Okay? That's not on the test. This is the bad thing though, if you get one, you tend to get another one. That recurrence is common. Alright, so we don't know exactly why you get it. We know dehydration, low fluid intake is a big one. A lot of people have a metabolic risk factor, like people that have gout, they have too much uric acid in their blood. Anything that gets in a high concentration in the blood can form a stone. A lot of these stones are made out of calcium. People that really overdo calcium supplements and that thing. This one, too much oxalate in your bloodstream. That's from eating a lot of spinach or other things like that. Y'all don't have to memorize that. It's a metabolic something. But I would say you probably want to think about calcium being one of the main components of a stone. But this is red. So what does that tell you when you're studying and taking notes? That's kind of important. Dietary habits, if it's this one, uric acid, that's from too much purine type foods like, do y'all know what purine foods are? Shellfish, red meat, organ meat, beer is a byproduct of purine metabolism. Okay, so here's the patho. You got that stone, and it flows. If it's in the kidney, a lot of times just hanging out, it don't really hurt. But when that puppy hits that ureter, and it starts going down that ureter and kind of scratching and clawing its way down, that's where the pain comes in. These people come in like this, doubled over in pain, yelling, because it's so very painful. That's called renal colic, by the way. The pain of a kidney stone is renal colic. And the pain tends to come and go in waves. Why do you think that might be? That peristalsis that we talked about, remember at the very beginning? Okay. So, say one side of your kidney is, one side of your ureter is blocked, completely blocked. You got two of them. One of them's blocked. What do you think that ureter is going to look like above the blockage? It's going to get big because your kidney doesn't know it's still making urine. And you're blocked, that's called hydroureter, okay? And then if that is not resolved, then that kind of like, it's hard, back it up with heart failure. If I'm backing up from the ureter, where's all that urine going back up to? The kidney, and that's called hydronephrosis. If it's not fixed, if it's temporary and we can clear the blockage, that's great. But hydronephrosis can cause kidney damage and end-stage renal disease. And if you've got bilateral blockage, what do you think? Is that a mess? Terrible mess. Okay, that's an emergency. Okay, we talked about kind of all these things. So things in your urine, you got all kinds of crystals and things in your urine. Anytime all that gets concentrated, some kind of stone can form. That's why low fluid intake. Remember we talked about your urine? It gets all dark and it's going to have a greater concentration that can set the stage for stones to form. Here we go. Pain. It's called renal colic. They may have CVA tenderness, but these are the red things. They may have the signs of a lower UTI like urgency, frequency, and dysuria. Okay. Hematuria from those picture that stone looking like a sand spur. You know that you get in your feet at the beach, and it's that thing with the tons of the little spikes. Think about that tumbling down your ureter. It hurts, and you're probably going to have hematuria because it's going to be causing bleeding. Okay, and it can have scarring. So how do we diagnose it? I'm going to tell you something. You know when they come in the emergency room. But they may have a family history. We can see it on x-ray, ultrasound. You can see a little twinkling on ultrasound. And then when they do pee that stone out, we'll send that thing down to the lab, and they'll analyze it. And depending on what kind of stone it is, might be the treatment. Like if all you do is live on spinach and you've got an oxalate stone, maybe you need to eat something else besides spinach. Or if it's a uric acid stone, maybe you need to cut down on the beer and shrimp. You know. So we'll look at it. And then we're going to treat them. Y'all, pain management is in red. That's the priority. Now, if they're completely blocked, that's probably going to become the priority because we don't want them to lose their kidneys. We're going to teach them about their diet, how you need to drink more fluids. And usually they're going to pass this thing. Hopefully. Y'all know what pass it means. You've got to be in pain until it comes on out. But sometimes it's too big and it won't come out. So we may have to do this. It's called lithotripsy. We're going to bust it up, okay? So you can either do this with shock or sound wave type things. This is fluoro. You find it, and then you kind of send those shock waves, and it breaks it up. It breaks up that stone, and you pass it on out. And so as nurses, we would, Mr. Cooper, I don't know if she's going to bring it, but y'all know what a filter looks like. So sometimes we would get them to pee into this little container or pour their urine in it, and we can filter their urine and catch the stones. We don't want them to flush it. We want that urine, so we can send it down and send that stone to the lab. That's a big job of ours to get that stone. Get it? Get it. Okay, so this is hydronephrosis, y'all. This person did not make it, okay? And see how the urine backed up and it just destroyed that kidney. So we really are. So if I were dividing this up, my first set of topics would be the parts of the nephron. I'd study that. That would be one topic. Glomerulopathy is another. Obstruction another. You know, I've got 91 slides. I know how many slides I have. I have a lot. And then maybe pyelonephritis is next. You break it up by topic and only study just a couple or 3 topics a day. Pyelonephritis. Pyelo means the pelvis of kidney too. Kidney. So what typically causes this? It's an itis. A lot of times it's brought on by an obstruction. Pregnancy is a big risk factor for pyelonephritis. Instrumentation. What do you think that means? Ms. Cooper's going to talk about that this afternoon. What?
Sterile.
Yeah, like putting in a catheter. Putting in a catheter. Y'all are going to be putting in catheters next week in the lab. And we're going to be so strict on sterile technique because what can happen to that person? A CART, catheter-associated urinary tract infection. And y'all, let me tell you something, that can kill old people. It can kill you. Urosepsis, remember we talked about that with septic shock. Okay. Young women, mostly. E. coli is the main bug. Where does E. coli live? In the intestines. Comes out the rectum, right? This is why more women too. The urethra is shorter in females, and so they're more likely to have this E. coli infection. Okay? It can be on one side or both sides. So pathogenesis, infection, it's usually ascending, meaning It didn't come from the bloodstream. Can it? Yes, but it's usually an ascending infection, like it starts at the urethra or the bladder and moves up. And the main organism is usually E. coli. So that bacteria binds to those cells, you have an inflammatory response, and here are the big reds for this one. For pyelonephritis, CVA tenderness, if any of you have ever had it and somebody put their hand on your back and did that little pop, it is extremely painful. CVA tenderness, fever, and pyuria, and this means pus in the urine. So how would we know? What would that urine look like? Cloudy. And then they may have signs of a lower UTI, which is dysuria, urgency, and frequency. By the way, instead of memorizing those terms, what do they mean? What does dysuria mean? Painful urination. It hurts. What does urgency mean? I gotta go, and I gotta go right now. But it may be just a thimbleful. Do y'all know what a thimble is? You sew with it. I don't sew, but it's a little metal thing you put on the end of your finger. It's a little bit. And frequency means they're going every 5 minutes. Okay? They're peeing every 5 minutes, a thimbleful, and it hurts. That's typical signs of a lower UTI, really. Oh, look at all this. We know about that from today, don't we? Septic shock. Y'all remember what ours is? Yeah. You can't get their O2 up no matter how much oxygen you give them. Remember that? White out on the chest x-ray, decrease surfactant, that. Okay? And so we're going to diagnose it with a UA. Going to have bacteria or red blood cells, white blood cells in the urine. So what are we going to do for this one? We're going to give them antibiotics. And we're going to get them to drink a lot of water. Flush it on through. And if it's bad enough, they're going to go into the hospital. How do we know which antibiotic to give people? Right here. And y'all are going to have to do a urine CNS, a culture, for your checkoff. You're going to have to show us where you get that urine out of that catheter for your checkoff. And what's that culture going to tell us? It's going to tell us what kind of bacteria is growing. CNS stands for culture and sensitivity. So culture means it's going to tell me what kind of bacteria are growing. Sensitivity is going to tell me what antibiotic kills it. Right? We want to give the right antibiotic, don't we? Because we don't want to develop all kinds of antibiotic resistance. Okay, antibiotics and fluids. Woo. These are little abscesses all through this kidney here from pylo. And then this can become chronic too. We didn't talk about this earlier, but you know how big your kidneys are? They're busy little things, aren't they? They do a lot. I'm thankful for mine. They're about 5 inches tall, not very tall, about 3 inches wide and about 1 inch thick. There's sometimes I say, thank you, Lord, that my kidneys are working. Do y'all ever do stuff like that? I think I'm weird, but I do that. Thank you for these kidneys. All right. So chronic pyelo, I guess what I want you to see is this. Like sometimes people come in for hypertension and we can't figure out why they had it. Like chronic long-term hypertension, it could be from kidney disease. And it's discovered serendipitously or accidentally by finding, they come in for something else and we discover it. So try to fix the problem underlying. Antibiotic and support their existing function. I guess this is why I told y'all about kidney size. This next one. Normal size, not normal size. This is polycystic kidney disease. Poly means what? Many or a lot. And cystic is cyst. That's what happens with this. Y'all, it's genetic. It's always genetic. This is a genetically transmitted disease. You can have autosomal dominant polycystic kidney disease or autosomal recessive or polycystic kidney disease. If it's recessive, both parents have to carry the gene. Okay. The recessive one is evident at birth. So even a little baby may have, you could even palpate enlarged kidneys, have even elevated blood pressure. And then autosomal dominant polycystic kidney disease, they may not have symptoms even up until their 30s. And they usually start developing these cysts that you can see here at 30. And so they develop cysts in the kidneys and also in other organs too, like they can develop them in the liver, the spleen, other places. All right, so the patho here is you develop these cysts, and they fill with fluid. All that fluid that's going on in your kidneys, they fill with fluid, and you start to get these little out-pocketing, and when you have that, becomes a medium for bacterial growth. And these cysts even develop blood vessels, and people that have polycystic kidney disease, they even have, sometimes they have cerebral aneurysms that rupture because of the delicate vessels that are prone to rupture. So what's bad about this too is, going back, do you think the surrounding kidney tissue around these cysts is going to be able to function like it's supposed to? No. Okay. And so these kidneys enlarge like you saw. We talked about they're susceptible to rupture, and it's very painful too when these little cysts or big cysts rupture. That's quite a large kidney. And so here are the things that you would see is pain from the cyst rupturing a lot of times, pressure. They can develop stones. These vessels can rupture. Certainly CVA tenderness. The renin-angiotensin-aldosterone system kicking in, so they'll have hypervolemia and hypertension. So treatment, diagnosis, I wouldn't concentrate tons on diagnosis. They may want to get genetic testing to see what kind it is. You can certainly see these on x-rays, ultrasounds. The treatment for this is going to be supportive. And y'all know what that means. We're treating the symptoms. So if they have a UTI, we're going to give them antibiotics. We're going to give them something for pain. They may end up being a transplant candidate, okay? Or even liver. Hypertension, y'all know what ACEs and ARBs are. What does ACE stand for? Angiotensin converting enzyme. And we want to give them something to inhibit that. And then if they develop the ACE cough and complications, then we would give them an ARB. Pain, end-stage renal disease, they would have to have dialysis and eventually possibly a transplant. So that was another topic. Okay, cancer. You can get cancer of the kidneys. Renal cell carcinoma, I guess, would be the most common kidney cancer, even though these are not one of the most prevalent types of cancers. The survival rate is 70% 5 year, but if it's metastasized, then it's a very low survival rate. And the thing about this is, many times when this is found, it's already metastasized because they're asymptomatic in the beginning, typically. Higher in African Americans, don't know why, but interesting fact. So Here is the primary, these are the, we don't know what causes it exactly. We don't know what causes any cancer exactly, do we? But we do know their exposure to certain things. Cigarette smoking has a very big link to renal cell carcinoma. Obesity, maybe hypertension would be why more African Americans, because they have more hypertension. So maybe that's it. Diabetes, long-term use of NSAIDs. What's an example of an NSAID? Ibuprofen. Some people just pound NSAIDs all the time. They're over the counter, they don't know. And over long term, that can cause kidney damage and, in this case, renal cell carcinoma. People on dialysis for long term. Multiparous women, that's a risk factor. Y'all know what multiparous women are? Women who have had a lot of kids. I don't know why that's a risk factor. Patho, you don't have to know that. As far as where it starts and all that, I'm not worried that you know where it starts most of the time. I'm worried that you know this, that initially it may be asymptomatic, which means they don't know they've got it. And then all of a sudden they have hematuria, they have flank pain, which is around in here, and they have even a palpable mass. A palpable mass means you can feel it. Okay? But then, as with any cancer, they may have weight loss. A lot of our cancers cause us to have anemia, etc. Okay. Biopsy, T. Y'all remember what T and M staging is? What does T stand for? Tumor, nodes, metastasis. Tumor, nodes, and metastasis. And metastasis means what? Spread. Very good. So how do we treat this? Well, we can do radiation, we can do chemo. If it's localized, stage 1, maybe we can just take this capsule out. This one looks like it's gone into the lymphs, so that would be probably some chemo with radiation. And this is metastasis for sure. Take out the tumors. You can take out a whole kidney too. That's called a nephrectomy. Because we already talked about we can live with just one, can't we? Because we have a large renal reserve. Because how many nephrons do we have per kidney? 1 million. Well, let's see about Jeanette James here. Jeanette is 52. She's got flank pain. Ooh, and it's coming and going in waves. She's pacing the floor and moaning. Her husband took her to the emergency room. She had hematuria and some white blood cells in her blood. Her pain was 9 on a scale of 1 to 10, and they gave her some IV morphine for her pain. What do y'all think is going on with Jeanette James? I think so too. What makes you say that? The pain, and it comes and goes how? It waves. And what's her pain like? 9 out of 10, and she's pacing, and she's got hematuria. So, what caused it? Why is she hurting? It's moving, that sand spur. It's twirling down that ureter. Can y'all picture that? So that's why she's hurting, isn't it? And it's coming and going in waves because of that peristalsis. What if that renal calculus, what's another word for a kidney stone? Renal calculus, nephrolithiasis, if it's in the ureter, ureterolithiasis. What would happen if her ureter is completely blocked? What's that called? What could happen? They would have hydroureter, which means what? Urine's backing up above that stone, and then when it keeps backing up, where does it go? And that's called hydronephrosis. And why is that bad? If it's not cleared, your kidney won't be able to function. If you've got urine backed up and all that pressure is backing up, it can begin to destroy that kidney tissue. Why do we want to tell Miss James to drink more fluid? To be hydrated, because what was one of the main risk factors for developing a stone? When your urine's very concentrated, the blood is very concentrated with substances, that's when stones can form. So we want her to be hydrated. And she lives in the south, and she's hot, okay? What do y'all think? A, hematuria, the glomerulus is not supposed to let that through, is it? And oliguria means it's not working because you may not have that hydrostatic pressure. Nephrotic syndrome. Before you answer the question, I'll be saying, what is nephrotic syndrome? What is it? When you're spilling a whole lot of what? Protein. That's what I would ask myself before I even looked at the questions. Now, what happens in response to that? Which one does it not usually cause? Which one does it not usually cause? It does cause hyperlipidemia because we said that liver got nosy and got involved, and what did it start making? Lipids. What else did it start making? Clotting factors, okay? So we've got hyperlipidemia. Do we have protein in the urine? Yes, because that's what this is. Do we have edema if we're losing all our protein? Because we don't have that oncotic pool. This is what we don't have. Polyuria, which means a lot of TT going on. Okay. Who does have polyuria? Diabetes. What's the answer to that one? Yes, it's always genetically transmitted. Which one is later in life? Dominant. Yeah. All right. We used to call this renal failure. Acute renal failure, chronic renal failure. Now we call it kidney injury. It's the same thing. You're going to hear it called both things in the hospital. So let's talk about that. So a lot of times when your kidneys begin to fail or have some of the symptoms of failing, it can be reversible. Like, remember I told y'all in the ICU that I would be monitoring urine output every hour, every 30 minutes? Well, what if I noticed that it was dropping? Or what if I noticed that my patient was hemorrhaging? What if I started giving fluid? And what if we started doing something to treat it really quick? Then maybe that can be reversible. You know, they didn't have any hydrostatic pressure because their volume was low. We started blowing in fluids. Maybe we reversed what was happening, okay? So sometimes this stuff can be reversible if we are really diligent and catch it. So a lot of our ICU patients, y'all, experience acute kidney injury. Because what's wrong with them? Well, they're in ICU, number one, and they've probably got comorbidities if they're in there. What does that mean? All kinds of things, you know, multiple things going on. They may have chronic diseases. So they're very susceptible. 2 weeks to 3 months, a lot of times those kidneys can be back happy, okay? Oh my word. Does that make sense? If your kidneys suddenly don't work, what was that first slide we talked about? Every bit of that. Every bit of it. So if they're not working, you're going to have acid-base imbalances. Which one? If your kidney suddenly quit working, what acid-base imbalance are you thinking? Something metabolic for sure. It wouldn't be respiratory. Metabolic acidosis. They can't get rid of anything, so you're going to become acidic. Metabolic acidosis. Decreased GFR. So what's going to happen? Blood pressure, increased creatinine, retention of waste products. That's your BUN, nitrogenous waste. All this, okay? So alloguria, I already told you what that was. Anuria, that's nothing, y'all. 100 milliliters in 24 hours. That's anuria means not. So that's really, they ain't got no urine output, okay? Here are the risk factors. Diabetes, for sure, is a big insult to the kidneys. Heart failure. That could cause acute kidney injury, couldn't it? If you had like acute cardiogenic, like acute heart failure, cardiogenic shock, and your heart wasn't pumping, are your kidneys getting any hydrostatic pressure? No. You know, so just 20 minutes of not good blood flow to the kidney sets the stage for this. Hypertension, nephrotoxic drugs. What does that mean? Drugs that are toxic to the kidneys, and we'll talk about some of those in a second. And then if you're old, woo, look at that. This is how you need to study it. There's going to be a key word for each of these. Pre-renal, post-renal, and intrarenal renal failure or chronic kidney disease or injury. Not disease, injury. Here's pre-renal. Pre means what? Before. Here's the word. Here's your word. You might want to make a chart on this one. It's perfusion. There's no blood flow. Decreased perfusion. That's pre-renal. There's really nothing wrong with the kidneys, but they're not getting blood flow. Does that make sense to you? So what could cause that? Well, look at this. ACE inhibitors. What do? They vasodilate, don't they? What if your dosage isn't quite right and you're really too vasodilated? What does that do to the pressure? It decreases it. It's going to, people that take blood pressure medicine, sometimes their dose gets off, and what do? Have y'all ever seen anybody just fall out because of their blood pressure medicine? Yeah, it has to be adjusted, okay? So medicines can cause it. If you're dehydrated, can y'all see that all of this is no volume? Burns means all your fluid goes out to the interstitial space. Diuretics, you're losing your volume. All of this. Does that make sense? Pre-renal is perfusion. If you're making a chart. That's a great way to do it. Make a chart. I wonder what we're going to do for this. Y'all know what azotemia is. Nobody asked me. That's retaining waste products. Okay. What else could cause? Oh, look at this. A catheter that's kinked under somebody's leg that's unresponsive. This is obstruction. Post-renal. Your word for post-renal is obstruction. But going back to this one, what am I going to do? If it's perfusion, what am I going to do? For dehydration, what are we going to give them? Fluids. What if we're going to give them all the heart failure meds. What if they're vomiting? Fluids and antiemetics. What if they're hemorrhaging? Stop the bleeding and give them blood products. What if it's diuretics? I got to do a different kind or decrease the dose or whatever. I got to fix it. Post means after. Obstruction. That's our word. Obstruction. What could cause that? Well, we already remember I showed y'all the prostate gland. BPH stands for benign prostatic hypertrophy. Could that be an obstruction? The prostate gland obstructing? Remember we said the male would have a hard time initiating a flow of urine. Kinked or obstructed catheter, a stone. Whose fault is that? That's a nurse's fault, isn't it? If the patient's catheter's all kinked up under their leg and they're unresponsive and you didn't do a good assessment, pick up the cover. So I wonder how I would fix these folks. How would I fix the catheter? Unkink it. I'm going to unkink it. Make sure the urine's flowing. Okay? I'm going to fix that. This one's going to have a lithotripsy. Right? Drink a lot of fluid. This one may have to have surgery. Intrarenal means the kidney itself. Something is causing damage to the kidney tissue itself. So what could that be? Nephrotoxic agents, NSAIDs. Like if you take an ibuprofen today, 2 of them, are you going to have kidney injury? No. If you do that every day for 25 years, 2 or 3 of them, yeah, maybe so. That's nephrotoxic. Aminoglycoside antibiotics, streptomycin, tobramycin, certain types of antibiotics are nephrotoxic. The dyes we talked about, glomerulonephritis, pyelonephritis, a transfusion reaction, chemo, all of these things can cause damage to your kidneys. So I wonder what I might check as a nurse before I go in there to hang a nephrotoxic antibiotic. Before I go hang it, what am I going to check? I'm going to check their kidney labs. By the way, what are those? I'm going to check their BUN and creatinine. And y'all remember those peak and trough levels that we talked about for medication administration exam? Peak and trough? Remember that? If certain drugs, we get peak and trough levels on. And what if their peak is way, way, way too high? I'm probably not going to hang it, right? So nobody's going to tell you to check all these things. You just have to know because you're a good nurse of excellence. You are a USA SN. Are y'all a USASN that's squirming? We're going to get through this little part right here, and then we could squirm on to your break. All right. So does this make sense? Decreased glomerular filtration rate. Yes. Azotemia means waste products in your blood. We've got acute kidney injury. They're not working. Waste products. Fluid retention. You do need to make sure you understand these phases. So you've got an initial insult, whatever it is. If it's pre-renal, what could it be? Perfusion, some kind of perfusion problem, not enough volume. If it's post-renal, obstruction. If it's intrarenal, something that's damaging the kidneys themselves. So you've got that initial insult. It may take a while for you to notice anything's going on. Then you might notice oliguria, which is what? Less than 424 hours. And then they're going to start holding on to potassium and creatinine. Decreased urine output, that's the same thing as oliguria, that's redundant. Fluid overload and inflammation. Is that making sense to you when they start to not do their job? And then, oh, thank you, they're starting to recover. 2 weeks to 3 months later, they're recovering. That's the diuresis stage. What you have to be really careful of in this diuresis stage is this. A high urine output. They may be putting out liters and liters and liters of fluid, but it's dilute. It's not filtering waste products yet or concentrating urine like it should. So they can become extremely dehydrated. So we got to watch that in this phase. It's starting to work, but it's not concentrating like it should. And then here we go, recovery. Okay. We know what fluid overload looks like. This is what nitrogenous waste looks like. I'm going to talk about that with chronic. Hang on to that. We'll talk about that with chronic. So we already said pre-renal perfusion. We're going to give them fluids. Diuretics, maybe for oliguria, monitor their electrolytes, and dialysis. Hemodialysis, what do you think that means? Blood. Continuous renal replacement therapy, or CRRT, we do in the ICU, and it's dialysis that's like over a 24-hour period that's very gentle for people who can't tolerate hemo. Decrease a little bit more. What does chronic mean? Long term. So remember how we said that we had a large renal reserve? Look at this. You may have 75% of your nephrons lost, destroyed, gone somewhere before you have symptoms. Okay? So end-stage renal disease means that you're going to have dialysis, okay? These are some of the risk factors, which they kind of all make sense. You don't have to learn these stages in order, okay? But I want you to see that, you know, here's a normalist GFR, starting to get a little bit reduced, a little bit more severe, and now we're in kidney failure and getting dialysis, okay? So early on, the kidney compensates. How does it compensate? Well, remember I said there's a million per kidney? We don't need them all at one time. Well, they start recruiting, you know. It's like, yeah, we do need you now. Everybody that can work, come on, let's get busy here. Okay? The BUN and creatinine rise, which that makes sense. We may have to even restrict dietary protein with these people because the kidneys can't get rid of that nitrogenous waste product. And then, oh, look at that. All this happens. Erythropoietin what happens when your erythropoietin decreases? When your kidneys can't secrete this, what happens? You're going to have anemia because that's what tells your bones to make blood cells. What do you think your blood pressure is going to be, high or low? High. You can't get rid of any volume. We're talking about kidney failure here. Blood pressure is high. Can't get rid of any volume. Renin-angiotensin-aldosterone system kicking in. What acid-base imbalance did we say we're probably going to have? Metabolic acidosis. Fluid retention. Ooh. Hyper or hypokalemia. If your kidneys aren't working, hyperkalemia. Uremia means waste products in the blood. Your kidneys are atrophied, and you need dialysis. So this is what I said I was going to talk about with chronic, when your kidneys fail. Cardiovascular, we just talked about hypertension. Right now, we thought it through. We said, if they can't get rid of the volume, they're going to have hypertension, and that renin-angiotensin-aldosterone system's kicking in. Okay? Skin. Y'all, you can have such amount of toxins that you can't get rid of that they can have what's called a uremic frost, that you can even see it on the skin. That's pretty bad toxins. The immune system is affected by this toxic environment, so they're more prone to infections. Encephalopathy. Let's see. Have y'all talked about any encephalopathy yet? No, you're going to talk about hepatic encephalopathy next week. Renal encephalopathy, can you tell what that's about to be about?
Big brain.
Head, cephalus, head. Renal encephalopathy means that those waste products are going to start to cause the person to be confused because of this high nitrogen content in the brain. The brain's not going to function like it should. Thrombocytopenia, that toxic environment in the bloodstream is going to destroy platelets. Y'all remember that. Thrombocytopenia is platelets. And what happens when you have a low platelet count? Bleeding. What's normal platelet count? 150 to 450. 150,000 to 450,000. Anemia. We already talked about why, didn't we? That erythropoietin, not making red blood cells. Metabolic acidosis. Hyperkalemia. What do we worry about with a potassium imbalance? Heart. Hypocalcemia. not enough calcium, so they have osteodystrophy. We said that at the very beginning of the day today. Your body needs calcium. Where are they going to pull it from? Your bones. Do you know why they have hypocalcemia? Because phosphorus is increased. Phosphorus and calcium have a reciprocal relationship. And when the phosphorus is elevated, and it will be in this case, just like the calcium's elevated, potassium's elevated, the people are going to have a low calcium. Phosphorus and calcium work like that. So this is what happens with hypocalcemia. Do y'all remember the test? What's this one? Will you tap on the cheek? Bostic sign, hypocalcemia. What's the one where I do a blood pressure cuff and my hand starts to? Trousseau sign. Y'all remember that? We talked about that in when? Acid base. Y'all see how all this stuff ties together? Okay, same thing I just said. Just gave y'all a lot of pictures. All right, so how are we going to treat chronic kidney disease? They're going to be on blood pressure medicine because they have hypertension. We're going to give them, okay, so if they're acidic, what do they need more of? We're going to give them some bicarb. They can't make it. We're probably going to have to give it to them. We're going to put them on fluid restrictions. They can't handle the fluid. They may be on fluid restriction, sodium restriction. They can't. Y'all, we had this one man, he loved tomatoes so much. He loved tomatoes. They're full of potassium. He had some homegrown tomatoes and he was a dialysis patient. He ate them anyway. He ate a whole bunch of them. That man had to come in for emergency dialysis because his potassium level was so high. This medicine right here, sodium polystyrene sulfonate or Kxalate, is a medicine that we give to pull potassium off when they're hyperkalemic. Y'all probably don't need to know that. So we're bone disorders. Okay, this calcium carbonate, what that does is it binds phosphorus and helps get rid of the phosphorus so we don't pull the calcium from the bone. Give them vitamin D. They're malnourished, probably because they don't like what they get to eat, or they're nauseated. This is a medicine, Epiton. A lot of our dialysis patients, when they go to dialysis, they get this shot, and it stimulates the production of red blood cells. It's a medication that we give them. It's a synthetic erythropoietin is what it is. Pain, we got to be careful. Because what about it? Can they metabolize and get rid of medicine as quickly? We've got to be real careful how much we give people that are not able to get rid of it. And a lot of times they're depressed. You know why they're depressed? Do y'all know anybody that gets hemodialysis? So I looked up the numbers. I think there's 880,000 hemodialysis patients in the United States. Hemodialysis means they go to these centers and they get dialysis. They usually go 3 times a week, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, and they're there for 4 hours. Would you be depressed if you had to go get dialysis 3 days a week for 4 hours? Could you go to nursing school? So that's one reason they're depressed. Before 1924, people just died. We didn't have this. And then in 1972, it became like a law that people who had kidney failure could receive dialysis. And y'all seen those clinics around town. I always say it wrong. Frenius or Fresnius or whatever those clinics are. They're all over the place. So they have a shunt put in. And the blood is run through this and it cleans it out. And so pretty much that's when they're not peeing, so that's pretty much their urination, but they're getting the toxins taken out of their blood. Okay? That's hemodialysis. Do you think that would change your lifestyle? Okay. So we've gotten better about it. Like people can go on vacation now. They can set it up in different cities that they're traveling to, that they can have it. Certain cruise lines have dialysis on the cruise. You could work on a cruise ship as a dialysis nurse if you want to. I don't know if Disney cruises have it. Y'all, somebody look it up and see. All right, peritoneal dialysis is they could do this at home. And so they run this fluid into their peritoneal cavity, and they put this solution in there that pulls the toxins into the peritoneal cavity, and then the person opens up the drain and lets it all drain out. High risk for infection with peritoneal dialysis. And then transplant. So they'll leave the old kidneys unless they're a problem, like causing hypertension and acting up. They'll leave them and put the new donor kidney there. And then what does the person have to do the rest of their life? They have to take immunosuppressants and anti-rejection type drugs and watch that they don't get infections and that sort of thing. Did anybody look up Disney cruises and see if they do dialysis? They don't. There are some cruise lines that do it though. Royal. That must be the old people cruise line. Disney. There's kids everywhere. All right, so we got a lady or somebody, 23 years old, hit and run, multiple abrasions, a concussion, a cut on his thigh. He was found 2 hours after it happened, and now in the emergency department. He's lost 2,500 milliliters of blood. How much blood do we have? About 5 liters. Whoa. Okay. Okay. They put a catheter in, gave him some fluids, cleaned and sutured his wounds. His urine output's about 15 an hour. Normal or abnormal? What's minimum? So if he's going to develop a type of renal failure or kidney injury, what kind would it be? Pre-renal, post-renal, intrarenal. Pre-renal. Why? Because pre-renal is perfusion, and he's had 2,500 milliliter blood loss. He's lost half of his blood, hasn't he? Pre-renal. Okay? What might happen if we don't do some therapies? It's going to go into chronic kidney disease, right? He can have that acute tubular necrosis where those filtering tubules begin to die. So I wonder what we would do for that guy. What would we do for him that's lost 2,300 milliliters of blood and he's in pre-renal kidney injury? Let's give him some blood. Let's give him some blood. Y'all agree? We're going to fix the problem. Stop the bleeding, fix the problem. So we're watching his urine output. What other labs should we watch? What lab? BUN and creatinine, right? Which one's most specific? Very good. If it doesn't come to normal, continues to be diminished, what changes would happen? All that stuff that we talked about. You know, the metabolic acidosis, the acid-base imbalances, the anemia, the thrombocytopenia. He could have renal encephalopathy. All of those things, that hypertension, all of the things that happen from kidney injury. Last thing we're going to talk about for a few minutes here is urological disorders. One of those being incontinence. So this is the anatomy again. What else we got a fancy name for going to the bathroom, for urinating. It's called micturition. That's the scientific name for it. And I don't know if you've ever thought about it too much. Most of us don't. We just go to the bathroom when we gotta go, right? How do we know we have to go? We have to have our central nervous system intact. We have to have our sympathetic and parasympathetic intact to allow. Nobody sits here and says, hey, bladder, why don't you fill up? You know, detrusor muscle, relax so you can fill up. Nobody has to say, okay, now I'm waiting and I'm trying to concentrate so I can feel that I have to go. All of these things just happen. And then when you do feel the need to go, you got to have the cognitive abilities to know where the bathroom is and know where the toilet is, right? So it takes a lot to remain continent. What is continent? What is incontinent? You wet your pants, right? Continent means you can hold it and make it to the bathroom. This is post-void residual. Did y'all know? Kind of like ejection fraction cardiac. When you go to the bathroom, your bladder's not bone dry. If I did a bladder scan on you after you went to the bathroom, I would see if there were 50 to 100 milliliters still in there, that's called post-void residual. That's normal. But if we do a bladder scan on somebody and there's 2 liters in there, what do you think? So that's bad, isn't it? Yeah. Because your bladder only holds like 3 to 400. All right, so we're going to talk about incontinence and infection. We've already talked about infection somewhat. We talked about pyelonephritis. We talked about glomerulonephritis. We're talking about now a lower UTI. A lower UTI. And our body protects us. The pH in men and women, the urinary tract, the characteristics of your urine are bactericidal or bacteriostatic. The flow of urine, we want it to go one way. What does that do when you're going one way? It's flushing out bacteria. Okay, all of these things protect us. Women before menopause, estrogen is protective against infections. All right, y'all, millions and millions and millions of people go to the healthcare provider each year with UTIs. It's mostly women. Why is that? Shorter urethra. It's usually sexually active women. Celibate women don't tend to have a lot of urinary tract infections. So what's another risk factor? Sexual activity, yes. Okay, another word for this is cystitis, which means like a bladder infection. E. coli. Oh, let's look at some of the risk factors. These are different. We know about E. coli. Improper perineal hygiene. What is your perineal area? It's not perineal. Y'all don't say that when Miss Cooper comes in here. It's the area between your legs. What is good hygiene for a female after you go to the bathroom? How do you clean? Front to back. Does everybody know that? No. You do, because you're nursing students. Does everybody know that? No. Y'all, we had a 90-year-old woman one time kept having UTIs. She did not know that. And a nursing student was helping. Don't assume people know, because common sense ain't common. It ain't. Okay? Tight clothes. I got my tight pants on. Bath products like, bubble baths and those kind of things. Douches. Spermicidal jellies. An ill-fitting diaphragm. All those things are risk factors. Men, if a man gets a lower UTI, it's kind of unusual, but a BPH can cause that. The older you get, the worse everything is. Reflux of urine means, we want urine to go one way. But if it refluxes, that's a risk factor, because stagnant urine is a medium for bacterial growth. Now, male children that are uncircumcised, why? Because all of that smegma that builds up under that foreskin is bacterial growth. The word is smegma. All right. And catheters. So does everybody get a catheter? No. Miss Cooper's going to talk about that more. So you got to decrease defense. Your urine's stagnant. If you get a catheter, those little bacteria just go on up that catheter, and it can lead to sepsis. Here's the big reds of a lower UTI, and y'all have to know these: frequency, urgency, and dysuria. Y'all know them because 80% of women have probably had a lower UTI. Frequency, urgency, and dysuria. Y'all, typically with a lower UTI or a bladder infection, you do not have a fever. If you have all these signs and symptoms and you do have a fever, it might be something worse, like pyelonephritis. Okay? These are the big three. So we diagnose it with we can look at the urine, we can do a leukocyte esterase test and tell. Don't worry so much about this. We can do a urine culture. What does that stand for? Clean catch midstream. That's how you get a urine specimen if you don't have a catheter. Clean catch midstream means you clean off your perineal area, pee a little bit, stop, then pee in a cup. All right. Do you think you need to explain that to the patient? Yes. Yeah. Okay, we're going to treat it with an antibiotic. Y'all, this bladder analgesic, I already talked about it a while ago. Phenazopyridine or pyridium. That's the bladder analgesic that turns your urine that orangey red color. You gotta tell them. It scares them. Hydration. Cranberry juice. How many of your mamas told you to drink cranberry juice for bladder health? Like, yeah, my grandmama did years ago. This is before it was even real. It's a real thing. It really is a thing. That cranberry juice keeps those bacteria from sticking to the lining of the urinary tract. So it's a real thing. In fact, in nursing homes, sometimes they'll give them cranberry tablets. Coddies. I'm not going to talk a ton about that because Miss Cooper's going to talk about that this afternoon because every one of you are going to be here. And so it's a sentinel event. It should not happen, and everybody doesn't get a catheter. And look me in the eyeballs when I tell you this. Incontinence is not an indication for a catheter. It's not. Nurses want one, don't they? I can't tell you how many I've put in before we knew that it was so bad. Hey, doc, they're incontinent. Can I put in a catheter? Sure. We don't do that anymore, okay? So we're going to learn how to put those in next week. It's going to be fun. This is y'all think checkoffs are over when you get out of here? No. This is a catheter insertion form that I got from our hospital. And sometimes they make 2 RNs go in and one of them's watching the other one. Make sure they're putting it in right. Because CARDIs are a never event. They shouldn't happen. Okay. I would make a chart on the incontinence types if I were studying. Because you got to know the type of incontinence and what causes it. And we already know that incontinence is going when you don't need to go or you shouldn't go, not making it, all kinds. Involuntary, look how many people. Most people don't really talk about it. I mean, do y'all sit around and say, well, you know, I'm incontinent? People typically don't do that. And they typically don't report it to their health care provider because they're there for another reason. So older people, I think it's over 60, should all be screened for incontinence. Ooh, look how much money we spend. Have y'all ever been down that row at the drugstore? All that incontinence stuff? Here's the risk factors. Well, the older you get, you know, things happen. Childbirth. Y'all, they're worth it, but they can cause a little incontinence issues. Pregnancy, obesity, diabetes, neurological stuff. Okay, here we go with the types. Urge incontinence, overactive bladder. You gotta know it, okay? What causes it? You got an overactive detrusor muscle. It's in red there. You know what the detrusor muscle is? The muscle that contracts to expel urine out of the bladder. Well, it's overactive. And so you can't make it to the bathroom. You gotta go. This one is common in older men. It causes leakage. It can happen from, hey, if you're on diuretics or something like that, could that happen? Yeah. If you're getting older, if you've got an inflamed bladder, obesity, COPD, all these things can cause that, urge incontinence. Y'all, I'm hearing a lot of buzzing around up here. Y'all, we're talking about incontinence. We're almost through. Stress, this is the most common. What causes it? Weak pelvic muscles. Most of the time it's from childbirth. When you laugh or cough or sneeze, you couldn't overcome the pressure of that. You couldn't, your urethra wasn't strong enough to overcome the pressure, and so there you go. No more jumping on the trampoline, horseback riding, jumping on a pogo stick, if anybody ever does that anymore. Okay, childbearing is a big deal with that one. And sometimes you do laugh and wet your pants. That's a good laughter. But don't, when you do it all the time, it's bad. All right. Mixed is a combination. Y'all, this can actually, we can laugh about some of it, but it can disrupt people's their activities of daily living. It is a very serious, life-changing thing for this. So we want to be very sensitive to our patients. We want to ask them questions, and we want to find ways that we can get help for people that suffer from incontinence. Okay, overflow is the bladder becomes so full that it overflows. So who suffers from that kind of incontinence? It could be somebody with a neurological impairment, a spinal cord injury, that they don't have that. Remember I said you have to have your central nervous system and all that intact? If it's not, they don't, the detrusor muscle doesn't contract, they don't feel the urge to go, and so, they can suffer from neurogenic bladder. So that's the thing. Overdistension. BPH can cause it, an obstruction. So these people, a lot of them, we teach them to catheterize themselves. They can do an in and out cath on themselves, or maybe their family members can help them with an in and out cath. Functional means that, maybe they have dementia, or they've gotten so confused in the hospital, or maybe they can't get out of the bed because you've got them restrained and they've been hollering and yelling for somebody to come take them to the bathroom and nobody comes. Well, they become incontinent. So that's functional. They may not know that they have to go, they may not know the right place to go, etc. This is a treatment for some type of incontinence, stress, really. The bladder sling, have y'all heard about that on TV, where they sew a piece of synthetic or natural fiber to the stomach muscles, and then they bring it around the urethra, and so it can tighten up when the person coughs. So we can do devices, we can do, what's the exercise that you can do to strengthen your pelvic muscles? Kegel exercises. And so we would teach our patients to do, for what kind? If it's weak pelvic muscles, Kegel exercises should help that. We can take medicine for urge incontinence, that overactive detrusor muscle, anticholinergics to allow for the bladder to fill. There are certain medicines that we can take in surgeries. We may be wrapping this up. Cause of stress incontinence. Wait a minute. We gotta see about this. What's the cause of stress incontinence? B. Highest risk for UTIs. B. waking up, we're early. Enjoy your own lunch.